So before we start today's lecture, I have just a few points to talk about. This based on some of the questions I got over the weekend after the lecture, and also when I scored some of your OSP exams. So first, I noticed a lot of you, they know the answer, but they could not actually write the answer. So I think it's important for you to know exactly the name, the terminology. A lot of people are confused, about exactly what it means. So although I can tell if they know the answer. So I think you have to be careful, especially if it's not a multiple choice question. You have to spell this out. And I hope you're not confused about the words. Now with the GI, you'll find a lot of similarities. So you have to be careful. And you have to really memorize those words. I know sometimes it's difficult. It's kind of strange, it's not even English. So, but you really have to memorize these words. The other question I got repeatedly was, people ask me about the diseases. So when I put some diseases, the point of the class, the histology class, is not to discuss pathology or clinical application and diseases, but I try to make the integration and the link between what you study in histology and how this is reflected on the disease process. So I think it's good for you to remember some of these names, but I don't want you to go deep into the disease and ask about symptoms or signs or treatment or anything like that. Just whatever I list in my lecture as a name and what it means in the histology if it has the link. The other also question was, people ask me about the, when I list some of the mechanism or some physiology or biochemistry, again, I'm trying to make the link. When I put you something about the test receptors, you just have to understand how the test actually filled. So I put you some of the highlights of the signaling. The same when I put something about the Aggastic acid secretion, I just want to make sure that you understand the parietal cells are the one that make the acid and does not secrete HCl. It actually secrete the proton and the chloride and then you join in the lumen. That's the kind of things I need to bring out, when I mention some of this mechanism. More of this will be the details you'll find in the biochemistry or physiology, so you don't have to worry about the details. You just have to make sure that you understand these cells are the one where things are happening. And one more thing I noticed in the lab, I think some of you are still not quite sure about the tissue they are looking at. At this stage, you should know exactly how to differentiate between connective tissue, muscles, epithelium, glandular structure, and so on. If you can't, you probably are not looking enough at the slides. I think this program online, the Olivia, which is the scanned images, should help you. I think some of you still need to really look more on this. You should not miss epithelium at this stage. When somebody asks me epithelium and then he's showing me smooth muscle, not at this stage. You have to know this. Because from now on, all the system will rely on your understanding of the tissue that you covered earlier. We're not going to go again and explain to you what epithelium is. We're going to tell you this is the type of epithelium you should see, this is the type of epithelium this type of tissue you should see. So if you look under the microscope, look at the slide and you cannot see where the epithelium, you should actually spend more time identifying this kind. Okay? So this is based on the feedback I got from you and the question, which actually helped me to see where some of the points that we should cover more or maybe you should emphasize. Okay, so let's start today's lecture, Histology of the Digestive System 3. Yeah, and actually when I put 3 or 2 on the title or subtitle, it does not mean I'm classifying things, just slide number 2, slide number 3. So if you have submucosa 1, submucosa 2, it's not there is submucosa called submucosa 1 and submucosa 2, it's mine slide number 1 and 2. If you feel this confusing, I can remove that, I'm just used to this. Okay, histology of the small intestine and pancreas. So the objectives of today's lecture to describe the layers of the wall of the digestive system, the digestive tract. Again, you should know that by heart. You should not miss any of this. You should know the layer. I'm going to bring this slide every time we talk about the digestive system. Describe the layers of the small intestine epithelium, types, we'll list the types of epithelial cells in the small intestine, its function, and we'll describe the structure of the pancreas. and identify islet Langerhans. The pancreas, although it is very important, organ, but histologically it's not going to be much details. It's going to be more, emphasis with the endocrine probably histology next year, and also with the physiology and biochemistry of the pancreas. But when it comes to the structure and the structure, it's not that extensive. So the overall structure of the digestive system, again, glands, tract, accessories, we have been jumping between some of those different organs. I think I'm missing some of the slides. Okay, functions of the small intestine. It's the principal site for digestion of food and absorption, and also has some role in your immunity. The small intestine is divided into 3 segments. We'll cover this in details in anatomy. I don't know if we did or not, but the small intestine basically is divided into 3 areas. The first one that's followed the stomach is called the duodenum, followed by the jejunum and the ileum. So if you are not familiar with these names, I'm sure you will know in anatomy more. But just for now, remember these 3 names: duodenum, jejunum, and ileum. The general structure of the GI, you should know that. People still asking these questions. The mucosa are 3 layers. The lining epithelium, which is usually what's different between the different areas in the GI. Underlying connective tissue, we call it lamina propria, and the smooth muscle, muscularis mucosa. All 3 layers are the mucosa. So the mucosa here is made by 3 different tissues: epithelium, connective tissue, and muscle. Put that in mind. People ask questions in the lab that they've never heard it before. You should read the lecture or read the book. Followed by the second layer, the submucosa. So the way to identify the organ is by looking at the epithelium. That's why you should know what the epithelium look like. You cannot get confused about epithelium now. First, you look where is the epithelium, then you can get oriented. Now this is your loop, correct? Follow the submucosa, which is the dense irregular connective tissue, the muscularis, 2 layers, sometimes 3 like in the stomach, and sometimes called also muscularis externa. I use muscularis only because it used to be muscularis mucosa. They call it muscularis interna, so this was muscularis externa. Now they call the muscularis interna muscularis mucosa, so there is no reason to call the other one externa. Anyway, whatever book you follow, it's the same thing. And then the serosa adventitia. The serosa is going to be the one that has the mesothelial layer, thin, simple squamous epithelium layer covering the connective tissue. Adventitia will not have a serosa. I hope this is clear. Now we're starting with the small intestine, plica circularis. These are transverse folds in the inner surface of the small intestine. If you cut the small intestine open, you will find these folds like this. We call them the plica circularis. It's not complete circles. They cover almost half the circumference or 2/3. So it's not a complete circle covering the whole circumference. They call it plica circularis. Again, funny name, maybe you have to memorize it. So you cannot write in the exam something about this. No, half a name. You should know this. You should know how to spell this out. The folds involve an entire mucosa and portion of the submucosa. Again, you need to know what's the mucosa and the submucosa. Because here when we say that, assuming you know what's the difference. Okay? So this illustration show you. So we have the muscularis, and this is the mucosa and submucosa in between. When the plica circularis are actually formed by the surface epithelium, but sucking the submucosa in. Part of it are built making this plica circularis. Similar to the gastric rugae or gastric rugae. Again, the submucosa is making the core. So in this case, what we expect to see, mucosa on top of that would be the submucosa, on top of that is the mucosa. So you should hear, I mean, it's not, we don't see that in details, but you should be able to see muscularis mucosa, lamina propria, and epithelium, because this is all mucosa, and this is submucosa. So this is what making the plica circularis. This is the histological description of this. Again, muscularis mucosa, muscularis externa here they call it because put the E, but the submucosa is here, and then this making this folds to form the plica circularis. This is the epithelium, and then this is the mucosa, correct? Epithelium, lamina propria in between, and then muscularis mucosa, which you cannot see. But this is it. This is, you have to imagine this, because you actually were describing three-dimensional structure by two-dimensional images. So you have to have in mind that actually this is a three-dimensional structure. Submucosa sucked in, making this plica. So grossly they look like this, and this is the illustration, and this histologically is how they look like. I'm sorry? Here? Yes, so this is, from here is the mucosa, or you want me to label it on the slide? So I explain it again, not label it again. Because label it means I write on the slide. Yeah, so this is the mucosa. Starting from the layer of the muscularis mucosa, thin layer here. Lamina propria is the tissue, connective tissue filling between this epithelial, and this is the epithelium here. This is the submucosa. So the submucosa, part of it making the plica circularis, and the other stay spread here. And this is the muscularis or muscularis externa. Those PCSV and stuff, I usually explain that in the notes in the slide, so you can know that too. So the plica circularis is not present in the upper duodenum, but you can see them in the lower duodenum, and the prominent, and less prominent also at the ileum when it's approaching the colon. So basically at the beginning, at the end, they are much less. So at the beginning of the small intestine, the upper duodenum, and the end of the small intestine, when the ileum actually hook with the colon, you don't see this plica, so everything in between. So you're talking about 5-6 inches at the beginning and at the end. You cannot see those plica circularis in the small intestine. And when compared to the rugae, or the stomach, they cannot be completely flattened when the intestinal wall is distended. You remember with the stomach when we said that the rugae was basically to take the, the amount of food that you can put in the stomach so you can extend and flatten. But with this plica circularis, they will not disappear. They will be still there. So this is one of the big differences between them. Now, the epithelium of the small intestine is formed what's called villi. So these are finger-like or leaf-like projections of the mucosa, extended from the theoretical mucosal surface for about 0.5 to 1.5 millimeter into the lumen. So this is the plica circularis, the submucosa, muscularis mucosa. Now here you can see in this image. Now, if you look at this, we assume this is the surface epithelium. You can say it's making these projections up. So we call this villi, finger-like projections. So from the surface of the epithelium, they go up. This is a connective tissue core from the lamina propria, and then it's covered, making these finger-like projections, similar to the lingual papillae. But also, compared to the stomach, it is opposite. In the stomach, we have pits. The epithelium actually was invaginating, making a hole. The epithelium of the intestine making villi, the same surface epithelium. In the stomach, it goes down, making the pit and the gland down there. But in the small intestine, making villi, they go up. So making this villi. It's a core of loose connective tissue, the lamina propria, covered by the simple columnar epithelium, the type of epithelium making those villi, those cells, are simple columnar epithelium. Again, this is the same image I just flipped. And that's why you need to get, exactly how the epithelium look like, whether we put the image like this or like this. It's not right and left, it's not up and down, it is where the epithelium is. So this is important. You don't get confused by looking at the slide, it was different orientation than what you look. If you know how the epithelium look like, you should identify the epithelium no matter where it is. Now, the cells that making the villi, those simple columnar epithelium, are covered also by what we call intestinal microvilli. The cells of the epithelium of the villi, we call them enterocytes. They provide the major amplification of the luminal surface. So if this is the cell that we looked at, which was on the villi, they have this hair-like projection, they call the microvilli. Each cell possesses several thousands of those closely packed microvilli. This is an electromicroscopic image of the actually single cell, simple columnar, and you have those projections. microvilli. So we have villi and microvilli. We said the villus is about half to 1 millimeter. This is about 1 micrometer. So it's 1/1000th of the size of the villi. It's the hair, it looks like a brush border, they call it a straight border. Visible in the light microscope and give the apical region of the cell striated appearance. It looks like you have actually hair on top of the cell. They call it striated border. So between the villi, there are openings of short, simple tubular glands called intestinal glands or crypts, or the glands or crypts of lubricant. So these are the villi. Here, lamina propria. These cells are simple columnar enterocytes. Each cell will be covered by thousands of microvilli. So I have villi, microvilli. And if you look down here, this will be the plica circularis. So plica circularis will be covered by all these villi. The villi might by cells, and the cells I have microvilli. The epithelium of each villus continuous with that of the intervening glands. So we said the villi is actually elevation of the epithelium, but then when they go back to the surface, they dig in, making those glands. See, similar to the stomach, we said only glands, the pits. The surface epithelium will invaginate and making the gastric pits and the glands. In the stomach, the epithelium will go up on the villi, but it won't go back to the surface, it will go deeper, making a gland. So here it is, the villus, and then you can see there's a deep gland or crypt, the gland of lubricant. So it doesn't go and end at the surface, no, it goes deeper, digs deeper. The epithelium of the glands include differentiated cells and stem cells of the small intestine. We'll talk about the cellular details later. I think it's a nice illustration showing the villus and how they dig back in. So this will be here, if we imagine this will be the muscularis mucosa. This will be the lamina propria, or this yellow. You can see the epithelium here, surface epithelium goes up, making the villi, but then it goes down, making those crypts or glands. Clear? So the villi of the small intestine contain blood, microvasculature, lymphatic capillaries, they call them lacteals, and both innervation and smooth muscle fibers. If you look inside the core of the villi, which is made by this lamina propria, you'll find a lot of structures actually, an artery and vein, and lymphatic vessel. It's a blind ended, so it's not connected like the vessel, it's connected, just a dead end. Is the lymphatic. Also, some of the smooth muscle from the muscularis mucosa extends in, and the innervation. This is a high magnification of a villi. Again, you can see these are the glands here, crypts. This is the enterocytes, the cells covering the surface. And you can see in the middle of the core, the lamina propria, this space here is a lymphatic vessel. It's usually the biggest one, and a lot of time you can see that easily on the histological section. When you look at the section, you should be able to find some of the villi, and this central canal is going to be the lymphatics. We call it the lacteal duct or lacteal. Also, you can see some smooth muscle. I mean, it's not totally complete surrounding the lacteal, but theoretically it should be. But again, it depends on the section. Sometimes you can identify the artery and the vein. They're more difficult because of their size. The lacteal duct, you should be able to spot that. You can actually sometimes also see it in the cross sections, like a central hole in the middle of the lamina propria. So we have the villi and the lacteal duct in the middle, this lymphatic duct. We have also the capillaries, arteries and veins, smooth muscle. Now, as we talked about the stomach, the gastric pits and gastric glands, there are cells that's making this surface. The same with the small intestine. There are different types of cells that making the surface, the epithelial surface of the villi and the glands. I listed them here, and we'll go in details. Enterocytes, goblet cells, Paneth cells, M cells, the enteroendocrine and stem cells. First, enterocytes, the cells that's making the surface epithelium of the small intestine are called enterocytes. They line the surface of the small intestine, and they constitute most of the epithelial surface, so most of the cells. You see, covering the villi of the intestine, and the crypts are enterocytes. These are the absorptive cells, and they transport substances from the lumen, from the food digestion of the intestine to the circulatory system, so to the nearby blood vessels. There's again simple columnar epithelium, nucleus is basal. The arrow is pointing to these cells, not this one. It's these ones. They have the apical or striated or brush border. These are the microvilli. This is the high magnification, so you can see them. I doubt that you can see that as clear in the lab. You might see something to look like a line on top of the cells. It might not be as clear as a brush border like this hair-like structures up here. The microvilli increase the apical surface. So the thing why we have this plica circularis, these folds, and this villi and microvilli is basically to increase the absorption surface. Can you imagine? You know, the surface if it's that flat, but if you have the surface wrinkled like this, the surface is way, way bigger. And this is exactly, it's hundreds of times, you know, when you have those villi and microvilli. So the absorption will take time, and then you can absorb all the necessary nutrients. So all this stuff is basically, again, structure-function relationship. Why we have villi? We don't have the villi in the stomach. Because you don't need to keep the food in the stomach for long. There's no absorption. But with intestine, you need this. You need the food to stay longer. That's why we have this villi, making this structure, just make the time, takes time for the food to circulate through the surface, goes up and down, so stay longer. The microvilli also, can you imagine thousands of those per cell, you know, trillions of them in your body. So it takes really long time, so you absorb, enough nutrients. So here is a high magnification. This again, just to give you orientation. So this is a brush border. This is actually the columnar cells. The enterocytes are here. These are, some of those are just labeled as lymphocytes. Again, all these labels should be in the notes for this slide. Just to give you a brief function of the enterocyte. For example, if for the lipid absorption, this is how it goes. The lipids are in association with the microvilli. When you eat some lipid, it will become close to the microvilli, and then it will be internalized, and you will be seeing them as vesicles of the vesicles of the smooth endoplasmic reticulum in the apical portion, which you can see here. How clear this is. And then the membrane-bounded lipid can be traced to the center. You can see this goes down all the way down here to the center of the cell. And then the lipids will be discharged into the intercellular space, the space between the cells. This will leave the enterocyte to these spaces around here. And then the extracellular lipids, now it's extracellular because outside the cell, recognized as chylomicron, and they pass beyond the basal lamina here, and then you go inside the lymphatics or the blood vessel. Again, physiologically, it's very complicated. You will learn that in physiology. So I think I just give you an idea what does the enterocyte does. Just absorb the materials into your circulation. That's why you get it. The second type of cells with the enterocytes are the goblet cells. And this is the one that you see here in this histology. These are mucus secreting to protect and lubricate the lining of the intestine, similar to the mucus cells in the stomach, but with different function to some extent because there's no acid here. But they are interspersed among the absorptive enterocytes, means that between the enterocytes, every once in a while, you find those goblet cells. They are increased in number from the duodenum to the terminal part of the ileum. So the lower you go, you will find more of those goblet cells. The apex of the cell, which is this part here, containing a large accumulation of mucinogen granules, and this is especially stained. That's why it looks in the H and E, this will look clear, similar to the other mucus secreting cells. And the basal part of the cell will look like a narrow stem. Again, these are the criteria of the goblet cells. So you find that most of the cytoplasm is containing the mucinogen granules up here. The cell itself, you find them, very, very narrow stem. The third type of cells are called the Pancreatic cells. This is actually very important. They are located in the basal portion of the intestinal crypts below the stem cells. Earlier, I told you the intestines making those villi, but also the go deep under inside the lamina propria, making those glands or crypts. So at the base of those crypts, you find those Paneth cells. So if this is a crypt here, and this is the base, the bottom, and you can see those Paneth cells. These are exocrine cells, have large eosinophilic secretory granules. These red granules, eosinophilic means red because it's eosin is the red color. And they contain those in their apical cytoplasm. So you can see the nucleus basal, the secretions are in the apical part. This would be the lumen of the gland. Here it is. So those Paneth cell granules release lysozyme, phospholipase A2, and hydrophobic peptides. We call them defensins. They bind and break down membranes of the microorganisms and bacterial cell walls. So basically, it's part of the immune system. We eat a lot of stuff with our food, a lot of pathogens actually come inside the food, and the Paneth function is to take care of this. Very important, you can identify those easily. They will look exactly like that eventually. Very, very prominent granules, really very, eosinophilic granules, you can identify them. Where you locate those, you have to look at the glands, not the villi and the crypts, and usually the bottom of the crypts. Again, here it looks like at the bottom, and here is the cross section, it's sort of close to the bottom, and it's just a high magnification of this area zoom in. Next, we have those M cells, microfold. You cannot see those on the light microscope. So you just need to know how they look like theoretically. So these are epithelial cells that overlies Peyer's patches and other large lymphatic nodules. We have some more lymphatics, nodules and lymphatic cells in the lamina propria, in the intestine and other organs, and we can find those M cells. They're specialized for transepithelial transport of particles and microorganisms. So the antigen transporting cells. They have microfolds, not microvilli, on their apical surface. Again, you cannot identify those in the hematoxin and eosin. It has a pocket formed by this deeply invagination. So if you look at these cells, this is how they look like. They have this pocket. So making this invagination inside the cells on this basolateral membrane, which is the lower and side membrane, and the containing lymphocytes. Lymphocytes from the lamina propria will actually migrate to this invagination. The other two cells, the anterior endocrine cells, we cover that in the stomach, so it's exactly the same thing. Stem cells also very similar to what we covered before. These are the ones that germinate and making new cells for the small intestine, and they're found also in the basal part of the crypt, next to the Paneth cells, although the Paneth cells are the lowermost. Now, we mentioned the lamina propria. All this is talking about the mucosa. I'm sorry, the epithelium of the mucosa. Now, the lamina propria, which is the connective tissue, second layer of the mucosa. Again, lamina propria usually is a connective tissue, but in the small intestine, it's heavily populated with elements of the immune system. If you look at this, you only see things like lymphocytes and eosinophils, plasma cells. You will hardly see actually connective tissue. This is one of the criteria of the lamina propria in the small intestine. One of the things is because of the defense. You need a lot of immune cells, in your gut. And approximately 1/4 of the mucosa consists of this lymphoid tissue. So it's really occupying a big part of the mucosa, including the lymphatic nodules, lymphocytes, macrophages, plasma cells, and eosinophils, all type of immune cells. You can see this. You don't need to identify them individually, which cells is what, but you need to know actually the lamina propria contain in the small intestine contain a lot of lymphocytes and immune cells. Muscularis mucosa, again, nothing different than we have described before. The submucosa, again, is a dense connective tissue aggregated adipocytes a little bit in the small intestine. But there is a distinguished criteria or characteristic of the duodenum, which is the presence of this submucosal gland called Brunner's gland. If you look at the submucosa in the duodenum, you find these glands. These are branching tubular glands, contain both zymogen secretin and mucus secretin. So it's a mixed gland, mucus and serous. These are present in the submucosa and only in the duodenum. So how can you tell the difference between the duodenum and other part of the small intestine? By this. You find this Brunner gland, boom, that's it. This is the duodenum. No other part of the intestine will have this. So there should be one of these distinguished criteria. Easy, a lot of time we ask questions like that. What is this part of the intestine? And there's this gland. No other answer. There is the duodenum. The secretions of these glands has a pH of 8 to 9, so it's alkaline. So it contains neutral and alkaline glycoproteins and bicarbonate ion. This highly alkaline secretion protects the proximal small intestine by neutralizing the acid-containing chyme. This is the duodenum, which is the first part of the stomach. So the whatever comes from the stomach probably still contains some of the acidity. So you need a lot of alkaline secretion that's coming from these glands to neutralize, so it will not hurt the intestinal mucosa or epithelium in this case. And this brings the intestinal contents close to the optimal pH for the pancreatic enzymes, which also we need some alkalinity for this. Muscularis, again, inner layer and outer longitudinal, inner circular, exactly the same like the other layers. The inner layer was segmentation movements, and the outer layer is peristalsis. So we need to push your content similar to what the esophagus will do. So segmentation means it is going to squeeze it, and peristalsis is going to push it out. So this actually the inner layer is going to do that, and the outer layer will do this. Again, it contains between the two layers of the muscle, outer longitudinal, inner circular. You have the unmyelinated fibers, the mesenteric plexus, the same like we've seen. Again, and then we have the serosa. Now, I told you about the infiltration of the lamina propria with all this lymphoid tissue. They have a name for this, actually. They call it GALT, which is gut-associated lymphoid tissue. Some other places, they call it MALT, because associated lymphoid tissue, which is things like in the tonsils and other organs. But this is because it's so significant amount of lymphoid tissue, they give it a name. Now we're talking about the ileum. The lamina propria and the submucosa contain well-developed gut-associated lymphoid tissue. The whole lamina propria in the intestine, duodenum, ileum, and jejunum, they contain this lymphoid tissue, and in the ileum particularly, they make aggregates. So it looks like almost a lymphoid organ in this area. It's the lamina propria and it's part of the submucosa. So when you look at this, you can see this is not connective tissue anymore, this is lymph nodes. Again, this is how you identify the ileum. So if you identify the duodenum by the Brunner gland, the ileum by the lymphoid tissue, and then the rest is going to be what? Jejunum, which has none of these. This consisting of the large lymphoid nodules aggregate, we call them Pear's patches. The underlying epithelial cells. So it's not on top of the epithelial cells, it underlies it, the lamina propria and in the submucosa. Now, diseases of the small intestine, just want to mention one which affect the function really bad. It's called celiac disease. Celiac screw. It's a disorder of the small intestine mucosa, causes malabsorption and can lead to damage or destruction of the villi. Actually, it's more common than we think. It's an immune reaction against gluten with other proteins. Have you heard of this? People have gluten sensitivity. What it does, it actually, you lose your villi. And then those people get diarrhea, malabsorption because of the reaction to this protein. That's why you see a lot of products. I think I don't know here, but in the US it's very popular. Any grocery store you find gluten-free. It's variable degrees of the sensitivity. Not everybody has to have a severe disease attack, but some people actually have malabsorption, mild malabsorption because of this. They react a little bit and sometimes develop over time and gets worsened. So the gluten actually is in wheat. I mean, unfortunately, it's in the bread that everybody eats. So they try to make these pretzels and bread that's gluten-free. They're, of course, expensive. Of course, anything that people think they can benefit from, there is the price. But it's caused by this immune reaction. The resulting inflammation affects the enterocytes, leading to reduced nutrition absorption. I just put this histology. You can appreciate actually the villi are gone. It's actually a flat surface, smooth surface now, basically. So if somebody has this, is not the absorption. We told you the villi actually increases surface absorption. Can you imagine somebody lost the surface? They're having issues with absorption. So that's only one disease I want to point out. So in summary, we cover the plica circularis. We said these are the folding of the submucosa, similar to the rugoid intestine. We cover the villi, intestinal glands, the crypts of lubricant. We cover also the different types of intestinal epithelial cells, enterocytes, goblet cells, Banach cells, M cells, endocrine stem cells. Submucosa, we mentioned the Brunner's gland, the duodenum. They also the muscularis, inner and outer, and the serosa, and the lymphatic, as I said in the area. And one disease of the small intestine, celiac disease. Again, you don't need to know about celiac disease much. Just know that this disease will cause malabsorption because the villi disappear. Reaction. Pancreas. Few slides only, since actually it should be covered extensively in other disciplines by chemistry and physiology. So it's a gland that have head, body, and tail. You know that more in the anatomy also. It has a loose connective tissue capsule. So it's a thin capsule that's making not similar to we have a thick capsule making the salivary glands. And have also septa like any other gland, extending into the gland, dividing them into lobes or lobules. Any gland will have the septa coming from the capsule and dividing into small lobules. The pancreatic duct, the duct of Wirsung, extends through the length, as you see here, of the pancreas, empties inside the duodenum. This is just a review. You should know more details in anatomy. It's an exocrine and endocrine gland. It has exocrine component and endocrine. Exocrine, it means it's going to drain into a duct. Endocrine means it's going to go right inside the blood. So the exocrine components synthesize and secrete enzymes into the duodenum. The endocrine part synthesize and secrete hormones, insulin and glucagon. So the exocrine pancreas is closely resembles parotid gland, similar to the salivary gland, acinine. So, and also has a duct. So if you look at this acinar structure, similar to the gland, which is very similar to the parotid, it also have a duct that carry these secretions. One feature here is that the initial duct that leads from the acinus, which is intercalated, it's similar name to what we've seen in the salivary glands as well, actually begins inside the acinus. So usually the duct is going to start up here where the acinus ends, but actually this duct, the intercalated duct in the pancreas, start inside in the middle of the acinal structure itself. The duct cells located inside the acinus, we call it centroacinar cells. So here it is. You can identify this on the H&D in the lab. So you look for this centroacinar. It's also one of the criteria. You can tell there's a pancreas and not a salivary gland. In this illustration, it shows you also, this is the acinar structure. The intercalated duct is embedded inside. So these are the lining cells. This will be the centroacinar cells. The cells that inside the cell from the duct that's inside the acinar structure. The mucus secretion is less alkaline than that of the surface epithelial mucus, and it's more soluble. Also, the exocrine pancreas is under the hormonal and neural control. The secretion of the chylocystokinin, CCK, is the principal regulator of the exocrine pancreas, and is secreted by the interior endocrine cells of the duodenum. So the duodenum secrete this, CCKs, and they control the secretion of the pancreas. The entry of the acidic chyme into the duodenum stimulates the release. So again, the digestion. Once the chymokine or the chyme comes from the duodenum, stimulate the secretion. So you know that there's food in and you need to secrete some hormones. So similar to the salivary gland, there is a duct for the exocrine part of the pancreas that carry the secretions. So intercalated duct is the one that we said will be starting from the inside the acini. They add bicarbonate and water to the exocrine secretion, so they are functional glands. These are the intercalated ducts lined by simple locuboidal epithelium. And you can see one in this centroacinar here. And I think there's no one. Yeah, there's another centroacinar here. And they merge into interlobular. These are the interlobular ducts, which is a larger one. And they increasingly increase the size of the epithelium. Now from low-columnar, locuboidal to columnar epithelium. The duct is going to be bigger than, I'm sorry, I didn't have an image, but they have, oh yeah, here it is. This is the intercalated duct. You see, the lumen is narrow, it's almost the size of the acini. You know, the epithelial cells will be tighter than the acini. The nuclei will be next to each other. Compared to the intralobular, it's still inside the lobule. So you have the intercalated intralobular inside the lobule. If you leave the interlobular, which is between the lobes, like this one or this one, you find connective tissue. That's why you identify you're outside the lobule, because now the connective tissues are bigger and they become larger, the tube in diameter, and the epithelium will vary. It will be stratified cuboidal, usually a couple of layers only. Anything above one is stratified. So it depends on the top layer. If it is cuboidal, we'll stratified cuboidal. If it's squamous, stratified squamous. But usually the cuboidal, you don't find multiple layers, except in certain sites, places like the bladder and stuff like that. But this will be only a couple of layers, but we go stratified cuboidal, and then you join the main duct, which can be stratified squamous, much larger. So the only difference between how they differentiate between the pancreas and the other salivary glands, the central acinar cell that you see inside the acini, but also there is no striated duct. Intercalated ducts are there, excretory ducts are similar, but the striated duct you can see only in the salivary gland. Best in the parotid, but they are present in the other. The endocrine pancreas. These are the islets of Langerhans. This is the endocrine. If you look at this pancreas, all this dark blue are the acini. The light blue color is an HND. These are the islet cell. These are cells that are making insulin and glucagon. Easy to spot. The different color when they stay in HND. It is the endocrine component. The small aggregates, they can vary in size. Usually small cells can be tens, 20, 30, and can be hundreds of thousands. There are 1 to 3 million islets constitute about 1% or 2% of the volume of the pancreas. This is a very vital organ. I mean, people get diabetes and disease like because of this very tiny organ. It's a problem to having with this. How can we replace? It's not really much. That's why you can lose those easy, and that's why people get type 2 diabetes. But you see, the volume-wise is 1 to 2% of the whole. Pancreas is not a big organ, and it's only 1%. So it's very, very small. They're most numerous in the tail. They look like polygonal cells, similar to hexagonal, arranged in short cords, and they are profusely invested with a network of fenestrated capillaries. If you look at them in high magnification, you find a lot of capillaries. Why? Because you need to get the secretion. It's an endocrine organ. You need to get the secretion right into the circulation. So they call it fenestrated capillaries, which capillaries have wide opening between the cells. It's called fenestration. So the cells can go, the traffic can go really quick between the secretion of islet and the circulation. They appear as clusters, I mentioned, of pale staining cells surrounded by more intensely stained pancreatic acini. All these are acini. This connective tissue septa, the light color or pale color are the islet cells. I'm going to just list this. This is very important for physiology and biochemistry. We'll talk about this a lot, and you keep that with the next whatever 5, 6 years of study. You'll hear every time somebody will talk about this. 3 principal cells. The alpha cells constitute 15 to 20% of the islet population located peripherally, secrete glucagon. The beta cells, most important, 70%, don't make insulin. And then delta cells, again, 5 to 10% of the islet cells, they are also situated or located peripherally, secrete somatostatin. There's also cells which is less important called PP cells, which secrete pancreatic polypeptide. The issue with this is it's difficult to identify those cells on the HND. You cannot differentiate which one is what. I mean, here they put some arrows, and these are the alpha cells because it's in the periphery, but it's very difficult to identify. You need immunohistochemistry for this, for the secretion. So, but this is a nice illustration actually showing you the location. So the beta cells are the blue, alpha cells are the periphery, and the delta cells here. But also, it's interesting, it shows also all these capillaries next to them. That shows you how close they are to the circulation. So I like this actually as an illustration, showing us also capillaries. And so the secretion from any of these cells will go right inside the circulation. Diseases, diabetes. I mean, everybody knows about this. I'm not going to talk about the, I mean, you kill this in physiology, I'm sure. But look at the WHO reported that in Saudi Arabia ranks the second highest in the Middle East with diabetes, and 7th in the world for the rate of diabetes. estimated about 7 million of the population, and almost around 3 million have pre-diabetes. That's a huge number. All of you will face people with diabetes no matter what, in your family, in your clinic, anytime. This is a disease everybody should know about, even the public should know about. It's a very public problem actually when you have a diabetes in this. So I'm just pointing this out to tell you, see how small these islands are, the size of Langerhans, but can make implementation or effect on the population as a whole. Just small thing, structurally, Allah subhanahu wa ta'ala created, but it has an impact that's like nobody can believe. But I'm just pointing out this how important of a public problem this is. The other disease I'm pointing, pancreatic cancer, although it's not common, but it's very, very severe. About 90% of those cases are pancreatic adenocarcinoma. The 5-year survival is 10%. Most of these patients, unfortunately, I know a couple of people actually died from this. And I mean, once it's diagnosed, most of the time, there's no return, 2 years, 3 years maximum. So this one with the disease you will see in the future, the problem is also the cancer soon will surpass breast cancer. It's increasing in number. So this is also another public health problem. This is a really bad thing because breast cancer are actually to far extent controlled. I mean, I work my basic work basically in cancer actually. I've spent the last 27 years working on cancer, bone cancer especially. So I know the prevalence of some of these diseases really well. But breast cancer is really under a lot of control. I mean, most of the times it became a chronic disease. People can live with this 50 years. But things like pancreatic cancer will stay behind. This is some of the future that you guys should be looking into, treating stuff like that. Hopefully, we can. But it's a very severe disease. Most of the time, it's silent, and by the time they diagnose, the patient's already in stage 2 or 3. It means outside the pancreas already. So there's nothing to do. People really get very, very weak, hectic, and they suffer a lot. So I just want to point out again, actually, it's not mostly it's the excretory part, not the endocrine part. So the endocrine part is diabetes, but the excretory part is this pancreatic cancer. So in summary, we covered the exocrine pancreas and their ducts, as well as the endocrine pancreas, highlighted Langerhans, and covered some of the diseases. Thank you. Attendance, I think.